Serotonin, that is 5-hydroxytryptamine, is synthesized from amino acid tryptophan by the action of the enzyme hydroxylase, which converts tryptophan to 5-hydroxytryptophan, and then a decarboxylase enzyme acts on this to produce 5-hydroxytryptamine or serotonin. And this serotonin is quickly degraded by enzyme monoamine oxidase to 5-hydroxyindole acetic acid. Actually, it is two-step. That is, first it is converted to 5-hydroxyindole acetaldehyde, and then another enzyme acts, that is aldehyde dehydrogenase, which converts this 5-hydroxyindole acetaldehyde to 5-hydroxyindole acetic acid. Okay, so that is the formation and degradation of 5-hydroxytryptamine. Now, where is it synthesized? Well, it is synthesized mainly at two places. One in neurons, that is the raffinucleus neurons in brainstem, because these are the serotonergic neurons, that is the neurons which release serotonin, and from there projections go to the entire brain. And second is enterochromaffin cells in GIT, where 90% of the serotonin of the body is synthesized. Now, the serotonin which is synthesized in these cells, it is stored there and it is released by means of neural and mechanical signals. For example, if there is a stretch in the intestine, then the serotonin is released and it acts on nearby smooth muscle and also on the blood vessels. Once it is released in GI blood vessels, even the platelets which are crossing from there, they pick up this serotonin from this GI blood vessels. So yes, lot of serotonin is present in platelets as well, but platelets do not have the enzyme for synthesis of serotonin. So these platelets pick up the serotonin from the circulation. So this serotonin basically acts as a neurotransmitter, one, and it also acts as a local hormone. That means wherever it is released, it acts either in paracrine manner or also on the same cells. That is, it acts on the platelets as well. If it is released from the platelets, it acts on the platelets as well. So neurotransmitter and as local hormone. Now this 5-hydroxyindole acetic acid which I talked about, that is the end product of the metabolism of serotonin, it is used as a diagnostic test for tumors that synthesize excessive quantity of serotonin. The tumor is basically the carcinoid syndrome. In carcinoid syndrome, basically a tumor of enterochromaffin cells of GIT. In this, excessive release of serotonin is there, and because of excessive metabolism of this same serotonin, lot of 5-hydroxyindole acetic acid is produced, which can be measured to know that yes, serotonin levels have increased. Now, this serotonin has lot of similarity with the catecholamines. For example, this decarboxylase enzyme which I told you before, this decarboxylase enzyme, it is a non-specific decarboxylase enzyme. That means it converts 5-hydroxytryptophan to 5-hydroxytryptamine. Also, it converts dopa to dopamine. That is one. Second thing, the serotonin which is released from the neurons or from the platelets, it is taken up by serotonin transporter which is present on the presynaptic membrane. So once this 5-hydroxytryptamine is released from the granules, it goes back inside the neurons or the platelets by this transporter, that is serotonin transporter. Similar to that, norepinephrine transporter is also present on these neurons. Okay, so this is norepinephrine transporter. Third similarity is that this serotonin or norepinephrine which goes inside the neuron, it is taken back into the granules by a transporter, that is vesicular monoamine transporter. So that transporter moves the serotonin or the norepinephrine into the vesicles. Then this drug Receptor actually blocks this VMAT transporter and can deplete the vesicles of norepinephrine and serotonin, because that will not work and the vesicles will not be filled with serotonin or norepinephrine. Then finally, the metabolism of serotonin. We said that there is monoamine oxidase enzyme which converts 5-hydroxytryptamine to hydroxyindole acetic acid. Similarly, norepinephrine is also metabolized by this enzyme monoamine oxidase. Okay, so there is lot of similarity between catecholamines and serotonin, and we will see in further lectures that the drugs which are like dopaminergic antagonists, they will affect the serotonin also. They actually block the serotonin receptors as well. Secondly, we will see certain inhibitors like MAO inhibitors, so they will affect both norepinephrine and serotonin metabolism until and unless it is for a specific MAO enzyme. Moving on to the different types of 5-hydroxytryptamine receptors. Well, there are 14 types of receptors. Broadly, it is 7 types. Okay, so we have HT1, HT2, HT3, HT4 and HT5, 6, 7 receptors, 5-HT receptors. And among this, again 5-HT1 has 5 types of receptors, HTA, B, C is not there because the C actually has come into 5-HT2 receptor. So it is A, B, D, E, F. Then we have 5-HT2 receptors, that is A, B, C. Then we have 5-HT3, 5-HT4 and again 5-HT5 we have 2 types, that is A and B. Then we have 6 and 7. Now these receptors when stimulated will have different functions. So first is 5-HT1 receptor, which is basically an autoreceptor. Okay. So this 5-HT1 receptor is present in CNS. Actually all types are present in CNS, but we will see that some other receptors have some other function as well. So 5-HT1 is present in CNS and it acts as an autoreceptor. Means what? Say suppose this is the 5-HT1 receptor, especially the A, B and D types act as autoreceptor. So this serotonin which is released from the neuron will act on this receptor and that is going to decrease the release of serotonin. Okay, so generally the autoreceptors tend to decrease the release of the neurotransmitter from the neuron where they are present, right? So here this autoreceptor itself is decreasing the release of the serotonin. So that was 5-HT1, A, B, D receptors. We don't know much function of E and F receptor. Then moving on to 5-HT2 receptor. 5-HT2 receptor is present in CNS. It is present in platelets. It is present in smooth muscles, so smooth muscles of blood vessels, intestine, bronchus, and it is also present on POMC neurons in hypothalamus. So in 5-HT2 receptors we have A, B, C. B we will not talk, we will talk about A and C. So 5-HT2A receptor, it is very important for smooth muscle contraction. Smooth muscle contraction. So let it be the smooth muscle contraction of the blood vessels, smooth muscle contraction of the intestine. Okay, so that is going to increase the motility. Smooth muscle contraction of the bronchus, so that will lead to bronchoconstriction. Then platelet, it causes weak aggregatory response. So that means the platelets will come together because of this serotonin. Okay. Then this in CNS, it is present in cortex. Then 5-HT2C receptors, they are present in the POMC neurons in the hypothalamus. And when these neurons are stimulated because of the serotonin, so here in the dendrites there will be 5-HT2C receptors and serotonin is going to act on those receptors. And when these receptors are stimulated, ultimately it leads to satiety. Okay, so serotonin is causing decrease in hunger, it is stimulating the satiety. Then it is also important for mood regulation, plus it is also present in choroid and that is responsible for increase in CSF formation. Okay, then 5-HT3 receptors, they are responsible for the emetic response. Okay, that is the vomiting response, and these 5-HT3 receptors are present in the chemo trigger zone in the medulla and also on the sensory and vagal afferents coming from the intestine. So when these are too much stimulated, you will have the vomiting response because of the serotonin release. And I told you before that the mechanical stimuli causes the release of the serotonin. So the serotonin is released from the intrachromaffin cells because of the neural and mechanical stimuli coming from this GIT itself, and it acts on this 5-HT3 receptors present on the vagal afferents and initiates the vomiting response. Then is 5-HT4 receptor, which is again present on the smooth muscle of the gut. So we saw 5-HT2 receptor present in the intestinal smooth muscle. We have 5-HT4 receptor also, which are present in the smooth muscle of gut. Plus they also act in the ganglia and cause increase in the acetylcholine release. So when this is stimulated, it is going to increase the intestinal motility. Okay, then we have 5-HT5 to 7 receptors. Again, not much function is known about these receptors, and clinically not much important as far as drugs are considered, but for the sake of completion we will study them. First is 5-HT5, which is responsible for circadian rhythm regulation. In fact, serotonin is the precursor of melatonin, and melatonin, we know, it is the circadian rhythm regulation hormone releasing from the pineal gland. Then we have the 6 and 7. Probably they have some role in cognition, and in fact some agonists of these are being tried in Alzheimer's disease. Okay, so these are the different types of the 5-HT receptors. We have broadly seen where these are present. Now we should also know that what are these types of receptors? Well, all of them are G protein coupled receptors except 5-HT3. 5-HT3 is a ligand-gated cation channel. That means when serotonin is going to bind on this receptor, there are channels which will open, that is the cation channels which will open, and it will cause the movement of sodium and potassium ions. Okay, so these are ligand-gated cation channels. Now amongst these different types of receptors, some are excitatory and some are inhibitory. We have seen that 5-HT1 is the autoreceptor, which is decreasing the release of the serotonin. So it is acting as an inhibitory receptor. So this is GI. So that is going to decrease the CMP levels. Okay. GQ is excitatory, which is basically acting via PLC pathway, phospholipase C pathway, causing increase in IP3 and DAG. If you really want to understand all these G protein coupled receptor, I will encourage you to watch my video on second messenger system. Basically, the title is Mechanism of Hormone Action. You check out that video to better understand what is this GI-GQ, right? So GQ is phospholipase C. Then again 5-HT4 is GS, that is the stimulatory type of G protein coupled receptor, which is acts by increasing CAMP. Okay, again G6 and G7 are of GS type, so they will increase CAMP, and G5 is the inhibitory type. So we can say 5-HT1 and 5. Okay, so 15 you can remember, 15 is inhibitory, that is it decreases CAMP. 5-HT2 is acting via phospholipase C pathway, increasing IP3 and DAG. Okay, and this is the exception 5-HT3, which is ligand-gated cation channel. Now, when we know that what will be the physiological effect after stimulation of these receptors, we can easily know that what will the agonist or antagonist do if they stimulate or inhibit these receptors, right? But before we go there, some actions of serotonin, further actions of serotonin we have to study. So I told you that yes, smooth muscle contraction it causes. Which receptor? It is 5-HT2A. So it is present on blood vessels. Direct effect is vasoconstriction of larger arteries and veins, but indirect effect is similar to that of histamine, what we studied, that there will be release of EDRF and this causes dilation of arterioles, and this is specially present in skeletal muscles and heart blood vessels. But remember, direct effect is vasoconstriction of these vessels as well. Okay. Second, because of the smooth muscle contraction, it will cause increased peristalsis, already seen. Then because of this direct and indirect effect on blood vessels, what is the effect on blood pressure of the serotonin? Well, there is a triphasic effect. Initially, we see a small fall in blood pressure, then there is a rise in blood pressure, and then there is slow sustained fall in blood pressure. So, why this is occurring? First is due to the Basalt-Jarisch reflex. So, this serotonin actually stimulates certain vagal nerve endings, and because of this, there is activation of this Basalt-Jarisch reflex. This causes bradycardia, hypotension and apnea. So there is presence of 5-HT3 receptors on vagus also. This stimulates the Basalt-Jarisch reflex. Then there is increase in the blood pressure. That is due to the direct effect of serotonin on the blood vessels. So vasoconstriction of large arteries and veins. So this veins, when they constrict, this is going to increase the venous return, and this further it is going to increase the cardiac output. So when cardiac output increases, since cardiac output is the determinant of blood pressure is going to increase. Then further there is fall in the blood pressure, and that is due to arteriole dilation. That is the indirect effect of this serotonin. When arterioles dilate, there is decrease in the peripheral resistance and hence there is decrease in the blood pressure. Okay. Then what are the other effects of serotonin? We have increased peristalsis. We have already seen smooth muscle contraction. Intestinal smooth muscle contraction will cause increase in peristalsis, and stimulation of sensory nerve endings can lead to itch and pain, similar to what we saw in case of histamine. Okay. So with this, let us move on to some drugs. Okay. So first is 5-HT3 agonist. What are these agonists? So we will see 5-HT1 agonist, 5-HT2 agonist and 5-HT4 agonist. Out of this, important ones is 5-HT1 agonist and 5-HT4 agonist. So we have two different types of drugs in 5-HT1 agonist. One is 5-HT1A partial agonist, that is the buspirone. It is used as an anti-anxiety drug. Okay, anti-anxiety drug. Now, this is basically a second line drug for anxiety, not the first line drug. First line drugs is SSRI. So when we are talking about anxiety, then again we will come back to these drugs. So buspirone, anti-anxiety, because serotonin has been implicated in disorders like anxiety and depression. Second is 5-HT1BD agonist, that is the 5-HT1B receptor or 5-HT1D receptor agonist, and these are the triptans. These are used for migraine. Okay, now what is the problem in migraine? So in migraine, we have the trigeminal nerve which is stimulated, and this trigeminal nerve releases certain neurotransmitters like CGRP, substance P. Now these substances cause vasodilation. Now, when we use triptans stimulate this 5-hydroxytryptamine receptor, and it causes decrease in the release of CGRP and substance P, thus causing decrease in the vasodilation or basically causing vasoconstriction. So, too much vasodilation due to CGRP leads to this headache, that is the migraine. Details we will see in another video where we will talk about the migraine and the drugs used. Okay. So, right now you just see that the vasodilation leads to a particular kind of headache known as migraine, and triptans, that is a 5-HT1BD agonist, are used to cause vasoconstriction by causing decrease in CGRP release. Now, there is another mechanism that this directly causes vasoconstriction as well. We have seen that hydroxytryptamine receptors are present on the blood vessels. There we studied that mainly it is the 2A type of receptor. But this is all speculative. We don't know for sure that how this vasoconstriction, maybe some direct effect of these agonists is causing direct vasoconstriction of this cerebral blood vessels. So, these are cerebral blood vessels. We are talking about headache, right? So, this is cerebral blood vessels. So these triptans, we have different drugs, but remember that these triptans are contraindicated in coronary artery disease because the direct effect of serotonin is vasoconstriction. So already in coronary artery disease, blood flow is the one which is affected. So we don't want to decrease it further. So that is why triptans are contraindicated in coronary artery disease. Now what are the different drugs? We have somatriptan, zolmitriptan, naratriptan, elatriptan, provatriptan, zolmitriptan. Somatriptan is the one which can be given oral, nasal or even by subcutaneous injections. So suppose when the headache starts, then this somatriptan subcutaneous injections are there which can be immediately given. Okay. Zolmitriptan is available for oral and nasal. So these nasal types will act faster compared to the oral ones, right? Then naratriptan and elatriptan, these are contraindicated in hepatic and renal impairment and also in peripheral vascular disease. Provatriptan again is contraindicated in peripheral vascular disease, and zolmitriptan is contraindicated in WPW syndrome, Wall-Parkinson-White syndrome. Okay, so those are the triptans. Moving on to the other agonist, that is the 5-HT4 agonist. First we'll talk. So 5-HT4 we saw was present in the intestinal smooth muscle, and its stimulation increased the motility. So obviously if 5-HT4 agonists are given, it is to increase intestinal motility. So yes, we have a drug metoclopramide which increases intestinal motility, and it is given in gastrointestinal reflux disease and also in GI motility disorders. Then we have other drug, tegaserod, which is given in irritable bowel syndrome with constipation, so that constipation is relieved. It is increasing the motility. Then another drug is there, 5-HT2C agonist. So that is lorcaserin, and we have seen that 5-HT2C receptor was present in which neurons? It was present in POMC neurons, and it was responsible for satiety. So when this agonist was given, it will cause satiety, and it was given in weight gain condition. So purpose was basically to lose weight, okay, because the person will feel satiety every time. So it was used for obesity to lose weight, but that drug has been withdrawn because of the cancer risk, right? So there is no 5-HT2C agonist which is being currently used. So in agonists we need to remember mainly three drugs: 5-HT1A agonist for anti-anxiety, 5-HTBD agonist for migraine, and 5-HT4 agonist which is a prokinetic for increasing the intestinal motility. Then we have 5-HT antagonist. So this is not 3 antagonists, 5-HT antagonist. So we will study mainly 5-HT2 antagonist and 5-HT3 antagonist, right? So agonists we studied 1 and 4, okay? Agonists are for 1 and 4 receptor, antagonists are for 2 and 3 receptors, okay? So 5-HT2 antagonist we have ketanserin. Ketanserin is 5-HT2A antagonist. We have seen 5-HT2A responsible for smooth muscle contraction. So if this drug is given, it will cause smooth muscle relaxation, and especially smooth muscle relaxation of blood vessels we are talking here. So this ketanserin is used in Raynaud's phenomena. Okay, Raynaud's phenomena is the condition where basically these blood vessels constrict in response to cold or stress. So we want the vasodilation to occur. So ketanserin is used. Now this ketanserin also has alpha-1 blocking action, and this alpha-1 blocking action will further cause vasodilation and can cause decrease in blood pressure, and in some countries it is used for hypertension as well. But you remember for now Raynaud's phenomena. Then second drug is cyproheptadine. If you remember this drug cyproheptadine, we also dealt in first generation antihistaminics. And this cyproheptadine has 5-HT2 antagonist activity as well. So it is both histamine antagonist, H1 receptor antagonist, and 5-HT2 antagonist. And this is used in carcinoid syndrome. Carcinoid syndrome, I told you before, that is a tumor of the enterochromaffin cells. So much serotonin is being released, and this serotonin basically it will cause hypertension because of vasoconstriction, then bronchoconstriction, intestinal smooth muscle constriction, and this is going to lead to diarrhea, tremor and clonus. Hyperthermia occurs because of increase in smooth muscle contraction as well, and the person will go into coma very fast. So fast action has to be taken. For that, sedation, intubation and ventilation is required, and cyproheptadine is considered for treatment to block the action of serotonin on these smooth muscles. And obviously with time tumor has to be removed. Now apart from carcinoid syndrome, there is another condition, that is serotonin syndrome. This serotonin syndrome can occur if we are giving serotonin agonist, right? We have seen serotonin agonists like buspirone. If we give that, plus we are giving some other drugs which increase the serotonin levels. For example, if we are giving SSRIs, SSRIs is serotonin reuptake inhibitors. So they will block that SERT, right, that we studied, that this is the SERT transporter. If this is blocked, then serotonin which is released will not be taken back, and there will be too much of serotonin which will act on its receptor. And we are already giving serotonin agonists. So that means there will be too much serotonin, right? So that serotonin syndrome also has similar features like that of the carcinoid syndrome. So why I am talking about this is that when we are giving serotonin agonists, we have to be careful that they should not be combined with SSRIs or also with MAO inhibitors. MAO inhibitors, they will block the degradation of serotonin. So again the serotonin levels are going to increase, right? So coming back to our antagonist, we have talked about 5-HT2 antagonist, that is ketanserin. Then we were talking about cyproheptadine. So it is used in carcinoid syndrome. Then another is that it is used in post-gastrectomy dumping syndrome. Now what happens in post-gastrectomy dumping syndrome, that the volume of the stomach has decreased because of gastrectomy. So a lot of food will dump into the intestine fast. Okay, so food is going into the intestine. Now this is going to stretch the intestine, and we have seen that how serotonin is released. That is because of the mechanical stimulus as well. So that stretch is a mechanical stimulus, and that is going to cause release of serotonin from intrachromatin cells. And what the serotonin will do? It is going to increase the motility. Okay, so this leads to post-gastrectomy dumping syndrome. That means all the food which has been taken, it will be because of increased motility, it will go fast out of the body without getting absorbed. So it will present as diarrhea. Okay, so if we give ceproheptadine, then serotonin will not be able to increase the motility, right? Then it also is used in priapism by SSRI. So priapism is a side effect of serotonin reuptake inhibitors, because there is increased serotonin. So that increased serotonin is going to increase the release of nitric oxide in the penile blood vessels, and that is going to lead to prolonged erections. That is priapism. So for this, we can give 5-HT2 receptor blockers. Then third very important drug is 5-HT3 receptor blockers, and we have in this cetrons, that is the ondansetron drug, which is given as antiemetic in case of chemotherapy induced nausea, radiation sickness. This we saw in antihistaminics, that promethazine is also a drug which is used here, but 5-HT3 antagonists are preferred, that I told there as well, right? So these are the various agonists and antagonists of serotonin. We have seen agonist of 5-HT1 receptor, where we saw two different agonists, 5-HT1A agonist and 5-HT1B and D agonist. Then we have seen 5-HT4 agonist, that is the metoclopramide. Then here we are seeing the antagonist, that is 5-HT2 antagonist, basically ketanserin and cyproheptadine. And then we have 5-HT3 antagonist, that is the ondansetron. So that was about serotonin agonist and antagonist, and as usual the video notes of this lecture are available for free download from the app. Thanks for watching the video. If you liked it, do press the like button, do share the video with others, and don't forget to subscribe to the channel Physiology Open. Thank you.